In terms of managing patients with ACS, I think the days are gone where pharmacists should be just focused on counseling patients on a single drug. I grew up in the age of Coumadin counseling, which sounds wonderful, but I always thought we should be counseling patients on VTE. Coumadin was just this one portion. I think the same thing could be true of acute coronary syndromes and managing patients with these chronic disease states, because the talk is focused on doing antiplatelet therapy. However, we're going to be sending these patients home on at least 5 new drugs. So we really need to focus in on adherence, getting to know our patients, because of the fact that they're going to be on aspirin, they're going to be on 2 antiplatelet agents, they're going to be on a statin, they're going to be on an ACE inhibitor, they're going to be on a beta blocker. And we really need to explain to them exactly why all these drugs are important. But especially with the dual antiplatelet agents, because if they become non-adherent within the first 30 days, their chances of having another event go up significantly. And subsequent MIs, your mortality rate is going to consistently go up. So I think adherence, explanations of why taking these drugs are important, building trust in our patients so that they will come to us if they're having complications so we could change their therapy, would all be a wonderful thing. So one other thing is there's a tool that we are going to discuss during the presentation called the DAPT Score. Was actually just came out at the American Heart Association conference in November. Was developed by the authors of the DAPT trial, so you would have to be careful in terms of utilizing in patients that would not fit the same inclusion-exclusion criteria from that trial. But the nice thing is, similar to CHATS-2 VASC in atrial fibrillation, this gives us a more objective way of looking at these patients, looking at risk factors such as diabetes, their age, have they had an MI in the past, and multiple other factors, to come up with a score which will give us an idea of what our number needed to treat versus number needed to harm might be in utilizing these agents long-term in patients. It may help us to objectify things a little bit better, and then we could also long-term study to see the patients that we actually carried therapy out and if they've had better outcomes or if their outcomes weren't as good. So I think those would be 2 things to look at on the horizon. And the DAPT score could be found at daptstudy.org.